We're at the CROI, the 2017 CROI. We're with Tim Henrich, and we started with you. You're with UCSD, I should say. You are in UC, University of California, San Francisco.
San Francisco.
And used to be with Brigham and Women's Hospital when
Correct.
you started the research. The research that he started was the Boston, quotes otherwise known as Boston patients. The 2 Boston patients that were, we thought, cured, and were for a time, but not really. And that's where this goes. But it's so important to get this research out and to know what it is that happened. And then that leads to other research. So give us a sense of first where, really briefly where we began and where we're at now.
Sure. I think this started back in 2012
Yeah.
when we first had these discussions, and we were just discussing the Boston patients A and B. I should mention one of those, Gary Steinkohl, has now talked openly and publicly about his experience about being Boston patient B, who went for almost 8 months, a bit under, off of antiretroviral therapy following his stem cell transplantation.
Without any
detectable virus either before or during the time that he was off therapy before virus came back. And he actually has talked openly now about how it was going from positive to negative to positive, to think that although there still was HIV in the body, that for those 7 to 8 months, that was really a life-changing event. I think it was really powerful to hear him speak about his experiences and about what it was like to be a participant in one of these trials and to be talked about anonymously in the news media. And although he certainly has expressed disappointment with the virus coming back, just the importance of these types of research studies to the field and how we can potentially learn from these and go forward. So as we say, you can't jump the whole flight of stairs. You have to go one step at a time.
And no, it's not really a failure. It's information.
Not at all. No, I don't think of any of these as a failure. I think to say that he failed a therapy or someone fails a therapy is really the wrong way to say this. We learn from everything that we do. So if we can manage to have a participant or an individual living with HIV go for almost a year or under a year, half a year without having to take antiretroviral therapy, then we've learned a huge amount, and we can apply that to the biology to make our treatments better and whatnot.
Yeah, so, and I think that's what we learned with everything, because we started out with AZT, single drug, not going to work. But it was the idea of putting 2 and 3 things together. And I think we're still there. We're still trying to go back to one drug. And we may try that with other things, but it's always good to find out what the threshold of success is and what we have to do, how many hoops we have to jump through to get to where we need to be.
Absolutely.
And that we always end up with a little more than probably what we need, because we want to err on the side of caution, I think. But we're doing the same thing with vaccines now. We're looking at, and with the multivalent approach to vaccination and to cure. So you're in the middle of that. I guess you probably know a little bit about the ideas of what they're looking at and how many different directions they're going to have to come at it.
There's many directions, and I think one thing that's going to come out during this meeting is that there's a combination approach, very much like antiretroviral therapy with AZT monotherapy to dual therapy to then finally combination triple therapy. We're going to see the same development in the HIV curative strategies field. So I think as we go forward, we're going to see either a combination of vaccination, targeting conserved areas of HIV that are hard to escape from those vaccines. We're going to see those used in combination with other agents that either help allow HIV to be recognized by the immune system that's being boosted, or even potentially using 2 different agents, non-vaccine agents, that either enhance the immune response to residually infected HIV cells, or augment those types of immune responses. So I think there's a lot of promising work also with these CAR, they call them CAR T cells, and how you can engineer cells to attack HIV that's residual in the body. So certainly I think there's a lot of exciting approaches that even 3-4 years ago, we would have no idea that these would be practical or even show any type of efficacy, but now we're starting to see some signals here and there. I think a large focus at this meeting is also going to be very early therapy, treating people extremely early after infection, either infants or adults, and to see if that has an impact on the viral reservoir, which I suspect it will.
So so that kind of gives, that little piece that you just gave us, that little nugget, is going to be really important in prevention. So people that think that they've been become positive or been infected, either in a way of PEP or just early treatment, if in fact they have the virus has seeded their body already. So if you think that you were infected last night, you need to let somebody know, like right now.
Absolutely,
but
yes,
failing
absolutely.
That, but failing that, if you think, God, that could have been a week later, it's still worthy to go in. No matter when you uncover that thought, it's still worthy to go in and get tested, and they would do a different test. Maybe they'd want to see viral load or something like that, because although the tests for the antibodies are still, I guess, effective. But the most important thing is to be tested immediately and find out, because if you are infected, it will lower the viral set point if the virus is starting to seed your body. Once you get the flu syndromes, which happen, what, weeks? Is it usually weeks later, or maybe
usually a few weeks after initial exposure?
It's still not too late, but obviously the less virus you have seeding your body, the better off you are.
That's correct. And I should say, just from personal experience at our own institution in San Francisco, that with the welcome rollout of pre-exposure prophylaxis or PrEP programs, we're now able to screen many people that are at high risk of acquiring HIV often, and are able, often because of starting antiretroviral therapy, at least 2 drugs, are able to treat people extremely early in the course of infection. I think it's going to be really interesting as we go forward with not only Jintanat Arnawach's Thai study, but also other cohorts in Africa and here in the United States of just treating very, very, very early. So as soon as someone may feel that they're exposed or has any evidence that there's a viral infection, whether it's just a blip of a viral load before it really starts to come up, or if it's a little bit later but it's before symptoms start, that's going to be really key, and I think an important population. Not only that, but it also gets people on therapy early. It reduces transmission potentially in this situation, and it's probably very beneficial, but I think we're going to be learning quite a bit about some of these studies.
So you'll evaluate, or there will be studies that will evaluate the efficacy, the sense of relative efficacy getting on treatment early as opposed to not.
Absolutely.
And so it seems like that's always going to be a really important thing. What area of other areas are of impact there? Is there anything else that we need to be, because I think we used to say treatment and then prevention and then there's care. It's all together. It's really all together, because treatment is prevention. Treatment as prevention is treatment as prevention. So we're really encouraging people to get thoughtful and being in there. But being engaged with having a place to go, and I think we talked with one of the other panels on having an access point for sexual treatment, whether it's STDs or whether it's PrEP or prevention or HIV. It's all, like you say, it's at-risk populations should really be very concerned about getting a sense of where they are and where to go if they need something in a pinch.
Absolutely, and having access to that, having information about those types of programs, not just studies, but clinical programs providing care, I think are going to be absolutely key going forward.
And one of the other things I'm concerned about is the difference between one's big city and a small city, because we can do a demonstration project in New York or Boston or San Francisco, very different than somewhere in the middle of the United States.
Oh, absolutely, or else in the world, 34 plus million people living with HIV and new infections every day, more in many areas than we would see in other areas. So I think absolutely that although the demonstration is important, in areas where we tend to have organized studies, we have academic centers that are really spearheading these types of studies or programs to roll out early care and other options. Yes, I think one of the biggest challenges is how do we then take that information that we've learned and how do we scale that to a meaningful global problem and a global program.
Now you have been at the beginning of a kind of a really important moment in history with potentially getting to a cure. Are you going to continue down that path? Are you going to do other directions? What is your...
Well, we're certainly going down that path.
Yeah.
We're still learning actually from the Boston patients right now. Obviously, we've had other stem cell transplant patients. We've had other studies ongoing in addition to early acute HIV treatment to see how that impacts reservoirs and persistence of latent virus. We're looking at other immunotherapies, other cancer treatments, not just stem cell transplant, and how those can potentially modulate or impact, again, persistence of HIV on or off of antiretroviral therapy. So at least our group is certainly plowing forward and using the information that we've gained so far to really go to the next steps, looking for novel markers of HIV infection in latently infected cells that are non-viral, for example, so we can identify these cells and target them.
There are markers and things out there that we don't know.
Oh, absolutely. Many things we don't know, but we need to find.
That's what I was going to say, because I think that we used to say that back in the, we know pretty much everything. I don't think we do. I think you just explained that, because it's really critical to know, to have that open eye moment to say, oh, we should be looking that way. That's maybe the real reason for everyone getting together at these meetings, because you have people that sit and they get into a panel or a symposium, and they say, oh, I never thought of that. And then now they employ that type of whatever it is that they've learned in what they're doing, and it might make a difference. Now, in addition to that, you sit down and have coffee with somebody that you might just have that moment, inspirational moment. I think one of the doctors at one of the opening sessions said they sat in a hot tub and had that eye-opening moment. I don't remember, that was in Boston. I don't remember who it was, but it was probably 8 years ago. So there's all places that this will come, those moments of revelation will come to that physician or clinician.
I really love these meetings like CROI or the International AIDS Society meetings with HIV Cure, simply because it brings together a diverse group of people, minds that have these moments, I'm sure individually and privately all the time, but to get together and to say, here's my idea, how can these be synergistic and compatible? It's really an important and also fun time in science to see that maybe we can make progress. Maybe we can really start to find pathways that are going to be feasible and scalable and have efficacy in prolonging ART-free remission. So
we have something at the CROI, just for those who aren't aware of how this operates. There's posters. There's what, I don't know, hundreds of posters, 800 posters maybe, in the poster session. And that may be the time where, would you say, the most one-on-one discussions, that maybe you have people bumping their heads together and come up with ideas too? They're pretty much proposing, they're selling what they've done. They've got to sell you on that.
That's right.
To convince you, because it's peer review.
It is the essence of peer review, as you guessed it. Someone presents their data, presents their ideas and some of the results from their ideas and their experiments. And it's up to the scientific community, but not just the scientific community, but community members to come and to question and to query and to say, okay, this is great, but what would you do next? How do we do this?
Or challenge.
Or challenge and say, well, but this is what we really need to do, and this is really what we should be doing next. And that's what makes these meetings really exciting. Yeah.
Well, it is exciting to always have you around to kind of open our eyes to maybe a way to look at things, and it's good to have people that are spirited the way you are, because I think I'm glad that it was you that went through this process with the Boston patients. It's probably hair pulling. I guess you lost a few.
I continue to lose.
But it's always good to have you here.
Thank you very much for
Thank you very much, Tim.
having me come out.
Yep.